I'll now call Dr. Sanjay De Bakshi. He's going to talk about choledochal cyst on a very important topic, defining the upper and lower limits of resection, because that is going to make a lot of difference in the overall management of these patients in future life. Dr. Sanjay Bakshi.
IHPBA conference held for the first time in Kolkata for the first time. Thank you. I see a lot of my friends around. Sadik is there. Right, and my brief today is choledochal cyst, defining the extent of resection. So I'm going to relook at the classification a bit. And in relooking at the classification, originally we all know about the Todani classification, type 1, 2, 3, 4A, 4B, and 5. But then we've gone slightly beyond. And if we subclassify, you look at 1A, where there's a cystic dilatation of the common bile duct, as well as part of this common hepatic duct and the extrahepatic duct. And this cyst is usually associated with an abnormal pancreato-biliary junction. We go to type B, where you have a focal segmental involvement. This does not have an abnormal pancreato-biliary junction, as you can see in this one. Typically extends down to the common channel, and they are associated with an abnormal pancreato-biliary junction, as in this patient out here. And finally, in type 1D, you have a cystic dilatation of the common duct and the cystic duct. In type 2 cysts, it's a true diverticulum, may arise from any portion of the common bile duct, and you can see that we had one such lady coming in with this. In type 2, you have two types of classification. The type 2, 3A, where the bile duct and the pancreatic duct enter a cyst, which then drains separately into the duodenum. Or in B, where you have a diverticulum of the intraduodenal common bile duct on the intraampullary common ductal channel. Cholangiocarcinoma has been seen, but it is important to note to define whether the lining is biliary or whether it's duodenal mucosa. And we know that 4A is both intrahepatic and extrahepatic cystic dilatation, and 4B are extrahepatic dilatation but no intrahepatic cysts. Of course, you have intrahepatic cystic dilatations, and if extensive, it's called the Caroli's disease. Type 6 cysts are very rare. You have a cystic dilatation of the cystic duct. Of course, we are all worried about the complications, of which stone formation, acute and chronic pancreatitis, rupture, cholangitis, but more seriously, we have biliary cirrhosis, bleeding because of erosion of blood vessels, a gastric outlet obstruction, gastric volvulus, interception, but we are most concerned about this disease, cholangiocarcinoma and a choledochal cyst. And as we know that the highest incidence is in the extrahepatic bile duct, medium in the gallbladder, and lowest in the intrahepatic bile ducts. There are frequent inflammatory changes leading to biliary neoplasia. Important note that cholangiocarcinoma are commonly found in the posterior cyst wall. Highest incidence in type 1 and type 4, both of which have abnormal pancreato-biliary junction, and the genetic events that precede it is a KRAS and P53 mutation seen in 60%, followed by DPC4 gene inactivation. And this is the incidence of cholangiocarcinoma and choledochal cysts, highest in type 1, 68, 21 in type 4, biliary line type 3, 10%, and type 5, 7 to 15%. But you have some suspicious factors. This lady initially came to us with a classic fusiform choledochal cyst, refused surgery, comes back 10 years later with a dilated intrahepatic duct. And the moment we found that, we saw and we thought that this was something that was serious. You know, we found some you can see little shadows out here, and that was a cholangiocarcinoma which had developed. And we become rather, so the suspicious factors are increased CA, a CA19-9, and an abnormal pancreato-biliary junction. But in multivariate, CA19-9 more than 37 is the only thing that registers. We have assessment of the choledochal cyst wall with intraduct ultrasound scans. This has to be done before sphincterotomy. because you need a bit of fluid filling up the common bile duct. And the normal common bile duct appears as 2 or 3 layers. It can identify suspicious areas in a choledochal cyst, and then you can take a brush cytology or an intraduct biopsy. And it has a very high sensitivity for diagnosing malignancy compared with fish or deer, or fish or deer alone. So, we need to find out what is the new classification of the pancreatobiliary junction. And there are different types of, I'm going to refer to the Comey classification. In type 1, the CBD enters at right angle between the ducts, either with type A, or without or with dilatation of the common channel. In type 2, you have the CBD entering at an acute angle, A without and B with dilatation of the common ductal channel. Comey described type 3 and several subclassifications, 3A being similar to a pancreatic divisum, 3B with no ductal versum. Type 3C also had several subclassifications. You have a C1 where there's a small communicating duct between the main duct and the accessory duct. 2 had a common channel made up of a common duct and the accessory duct of the same caliber. 3C is characterized by total or partial dilatation of the entire ductal system. The Japanese Society of Pancreatobiliary Medicine took the easy way out. 3 classifications: right angle A, acute angle B, type C complex. So they finished up there. But if you look at the Comey, type 1A and 2A are pretty straightforward. You can core down, write down, and remove the choledochal cyst, entire choledochal cyst. What do you do if you have a type B? Either 1B or 2B. You're inevitably leaving a portion of dilated duct behind. So you either have an option of stenting across, recurrent protein plug formation, and recurrent pancreatitis is possible. It also leaves a segment prone to malignancy. So is there a scope of doing a pancreatic or duodenectomy? 3A has a similar problem in the reconstruction of the common channel, has same type of problem. Again, is there a scope of doing a pancreatic or duodenectomy? In type 3B, because there's no ductal versum, you can actually take out the complete dilatation right down to the bottom without worrying about pancreatitis. Type 1C1, there's a communication, so the option is to either divide that communication or plan for a pancreatic or duodenectomy. C2 is pretty straightforward. You can remove the choledochal cyst without damaging the pancreatic duct. C3, you have multiple segments, and you can see in that diagram, it's best to go on the left side of the neck of the pancreas if you're doing a pancreatic or duodenectomy, because you want to anastomose to a single pancreatic duct, not multiple anastomosis. The incidence of post-excision malignancy has been reported to be 0.7%, and it may occur in the residual intrapancreatic portion of the choledochal cyst excision, and that was defined by Todani. So people have done a preemptive pancreatic duodenectomy. There were 59 patients, 4 underwent formal PD, and they're completely doing fine over a long period of more than 20 years. What about the upper limit? There's no histological difference between the dilated and non-dilated part. So the decision based entirely on morphology. Traditional excision of the dilated part and the hepatic or jejunostomy. But what happens if there's a dilated? Presence of dilatation should merit thorough investigation, because we've been caught out. Some of our patients didn't do an operation, came back later. We found stones, and we also found cholangiocarcinomas. They initially didn't have an intrahepatic dilatation. Now they had an intrahepatic dilatation. So I don't know whether that was an acquired issue. But we've had people saying that it's unnecessary to carry out a concomitant hepatectomy, as intrahepatic choledochal cysts of IHPR rarely show any malignancy. And they say that if you define a proper bile flow rather than a radical excision, it's the most crucial factor determining treatment outcome. However, the Japanese have said that malignancy has been reported in intrahepatic cysts. And my question is that you have to assess these as per your case. If you have a narrow stricture with a huge dilatation of the left duct, as in out here, you are forced then to do a hepatectomy. There's no sense keeping that behind. So, in patients who derive the most benefit from partial hepatectomy are individuals with dilatations and or stenosis of the intrahepatic duct stones, or parenchymal atrophy. There's no sense keeping them back. We've had a very large series from IPGMR in Calcutta of 329 patients, and that was a similar message that was coming across. You see, this was again reported from Turkey, and you can see that this left duct is completely damaged. There's no sense keeping it behind. Given a situation where both bile ducts and common hepatic ducts are dilated, a liver transplant may be the only option. This lady came to us at an age of 50, and by that time she already had fibrosis in the liver. So we obviously offered her an OLT, orthotopic liver transplantation. And there have been studies on the use of OLT in biliary cysts. As you can see from America, one of the highest series for 311, 215 were transplanted for Caroli's, but 96 for pure choledochal cysts. 50 patients underwent multiple organ transplantation in another series, 48 in Caroli's disease and 2 in choledochal cysts. But now comes a bit of a problem. It's a tough decision when you have the dilatation, when you have both massive dilatation inside the liver with fibrosis and you have a dilatation going down. See, combining pancreaticoduodenectomy with an OLT is a frightening procedure, but it has been done. King's College, the RELA unit, describes 4 patients. 1 was simultaneously done, and 3 had sequential, both an orthotopic liver transplant followed by a pancreaticoduodenectomy. And from China, we had one center which started off with an orthotopic liver transplant, found that the biliary cyst was too fibrotic and could not be resected, and they were forced to do a pancreaticoduodenectomy at the same time, though they did say that we would have rather done it sequentially. So some final thoughts. Excellent, good long-term biliary outcome in that series from Calcutta. Independent predictors were type 4A cyst, post-op bile leak, adult patients, longer duration of follow-up. Over a mean follow-up, 59 months, 2 patients developed malignancy. And thoughts for the future, because we've acquired a robot, and oddsboundly we've acquired an intraoperative radial ultrasound scan, and you can actually define there, you can find out whether there's a stricture or a narrowing in the hepatic ducts and tailor your treatment accordingly. I'm going to end with a brief walk through time, and I'm going to recognize some outstanding surgeons. Veta and Esler in 1723, Alonso Ledge in 1959, first classification of choledochal cysts. Todani did an overwhelming work, 1977, 1997, 2003, Comey in 1977, 1991. But do you know what? The important thing, because I started off training in medical college, and it was during my training that the hospital acquired an ultrasound machine. And we were very, I'm a bit of a dinosaur actually, so I've seen the advent of an ultrasound machine. And I can appreciate that the other timeline is this. 85, X-rays came in. 1898, Curie's discovered radioactive material. 1913, we've had people coming in for vacuum tubes, which enabled X-rays to be taken. 1942, Duchenne discovered ultrasound scan. William Clone, ERCP in 1968. 1970, Hounsfield and Cormack, CT scan, yellow because they got the Nobel Prize as a result of that. 1972, Raymond Damadian discovered and patented MRI. 1991, Walter and Morimoto established and patented MRCT. Now we have the intra-ultrasound scan. So, ladies and gentlemen, appreciate these outstanding gentlemen who were working with simple X-rays and then ultrasounds to define for us what we know now. as the true classification and subclassification of choledochal cysts. Thank you.